We are happy to introduce to you Dr. Bhayani, head and neck surgeon out of Rush University Medical Center in Chicago. Dr. Bhayani completed his training at the University of Texas MD Anderson Cancer Center and is passionate about delivering cancer care treatment to patients without significant compromise to their quality of life. He has done much research around quality of life after cancer treatment and has over 30 publications on these topics. Dr. Bhayani has a great talk prepared for us, and he was even able to invite one of his patients to join him later in the webinar to talk about her story and how she has managed her post-cancer survivorship. With that, I'll turn it over to you, Dr. Bhayani.
Cool. Thanks, Brittany. Thanks for joining us tonight on a lovely Tuesday evening. So my name is Mihir again, and I'm at Rush, and I wanted to kind of talk to you a little bit about really the significance of head and neck lymphedema, how we assess it, and sort of the treatment that's related to it. So just as a, disclosures. All right. So just, I'm on the Speakers Bureau for Tactile. So just as a quick poll, I just wanted to know who, what is your sort of practice area? Oh, we got 90 people. Great. So as you can kind of see on the screen, we've got about a third of folks are physical therapists or occupational therapists. And then we have speech language pathologists. We have a couple of physicians and lymphedema therapists as well. So it's good to see sort of a diverse audience. Anyway, I forgot to say, just make sure you feel free to, as we go through, to ask questions, to Brittany, and then we can kind of relay them through and go through it at the end as well. So, so quickly, just to sort of why are we sort of here, and what's important is that so head and neck cancers overall have been going down over the last 20 to 30 years, really related to sort of smoking initiatives that were started off in lung cancer. But really, interestingly enough, and sort of in the late 90s, early 2000s, we started to see this uptick in head and neck cancers overall. And so you kind of see this sort of overall trend line is going up. And then when you look at sort of the subsites itself, oropharynx cancer seems to be going up as well. Similarly, you kind of see a little bit of oral cavity sort of trending upwards. And a lot of that's related to HPV. And, the prevalence of HPV or the incidence of HPV continues to rise in our population. And it is really well known now that it's a strong contributor to the development of oropharynx cancers and base of tongue cancers. So, and that's where, this sort of the oral cavity component, we might actually be seeing that trend line going up is it because some of the base of tongue cancers that are typically in the oropharynx are actually coded into the oral cavity as tongue cancers. So this is data that was extrapolated off of the SEER data set, and where they're looking at is that, the trends in sort of cervical cancers are going down over the next 2 decades. However, oropharynx cancer is just skyrocketing. And if you actually kind of look at it, it is going to far and away be one of the most common cancers that exists in our population. Hopefully we see this plateau over the next decade, but it doesn't seem to be the case. So how are patients getting treated? Well, a decade ago, or actually 2 decades ago, patients were getting treated with mostly chemotherapy and radiation. And this is sort of this upward swing on this green line is really a sign of the introduction of different chemotherapies, different radiation techniques, and then also this organ preservation initiative that started out in the late 80s and early 90s out of larynx and hypopharynx cancers. And so, this sort of transitioned into the treatment for oropharynx cancers as well. A more contemporary data set, though, is that we looked at, after the 2009, when more minimally invasive robotic surgery became FDA approved, and we started to see sort of an upward trend in the use of surgery as the primary treatment. But what's critical to remember here is that even though the trend is going up, still 2/3 of patients were getting treated with chemotherapy and radiation, but also in this grouping of 35% of the patients that were getting surgery, almost 80% were getting some type of adjuvant therapy that was related to radiation. So why is this important? Well, we have these patients getting treated, and we're seeing a lot more HPV positive cancers. Well, if you look at the survival for an HPV related cancer, if you're HPV positive, it's about 80%. Well, that number is actually probably a little higher in a more contemporary data set. This is data from probably about 6 years ago, or actually this is a decade ago, but this is coming off of a retrospective trial. But if you look at sort of more contemporary data, HPV related cancers, the survival is closer to 90 to 95%. And if you look at the HPV negative population, it's closer to 57%. So, we're getting more patients who are HPV positive, and we're getting them to live a lot longer. Well, why is that important? Well, this is one of probably the most critical slide here is that, and the basis for why we need to talk about what we're talking about, which is that there was 10-year data after RTOG 9111 that showed patients who got concurrent chemoradiotherapy were 40% more likely to die of treatment-related issues and not the actual treatment, not the actual cancer. And so that means that, RTOG 9111 was a non-surgical treatment for larynx cancers, and they compared radiation therapy plus induction, radiation therapy that was with chemotherapy that was given concurrently, and radiation therapy alone. And really their primary outcome was actually laryngectomy-free survival, which meant that the patients who got treatment, who was least likely to get a laryngectomy. Well, naturally, the concurrent chemotherapy and radiation group was the least likely for going on towards developing laryngectomy, or having a laryngectomy. However, what's critical to remember is that these patients then had to live with the side effects of their treatments. So we kind of went into it though. So why is this relevant? Well, we have this increase in the HPV related cancers. If you again extrapolate oropharynx cancer out towards the next few decades, it will become the third most common cancer in men by 2045. HPV related cancers have a high survival rate. And so that means that all these patients are surviving through their treatment. And again, most of these patients have some sort of radiation therapy as part of their treatment plan. And so the side effects of this therapy can result in significant morbidity and mortality. So what does it mean to be a survivor? Well, being a survivor is a person that's diagnosed with head and neck cancer until the end of life. And right now we have close to 500,000 survivors from head and neck cancer in the United States. And each survivor has to live with the changes to their body as a result of treatment. So this is the list of the survivorship topics that are sent out through our American Head and Neck Society. So I'm on the survivorship committee, and at one of our meetings, the committee was tasked with picking various topics, and this was the list that was given to us. And we followed that up the following year, and there were actually additional topics to cover. So if you think about it, every patient deals with some component of this. And what we want to focus on are, the two components that I'm kind of most interested in are dysphagia, stricture and aspiration, and then lymphedema. So what about dysphagia? Well, as we know, the tumor treatment can create significant side effects. The impact on swallowing can lead to malnutrition and, leads to feeding tube placement. And in the head and neck population, about 50 to 60% of patients require a feeding tube. Okay. So patients can get a feeding tube placed either prophylactically, which is sort of a more old-fashioned way of treating a patient. But in many cases, patients are coming in already malnourished because their tumor prohibits their swallow function and they're unable to get enough nutrition. And then there's the reactive ones where, you're going through treatment and for one reason or another that you require a feeding tube, whether that be related to, pain from surgery, swelling after surgery, whether it be, mucositis after radiation therapy, et cetera. And so what are the effects of placement? Well, about 40% of patients who have feeding tubes admit to severe depression. And if you look at sort of quality of life scores across the cancer spectrum within the, at least in the oral cavity or the oropharynx, feeding tube placement actually is the number one reason to reduce quality of life in our head and neck population. And what's amazing is that in these patients, they're twice as likely to commit suicide. And there's about that's a 30% increase over the last 5 years. So, these patients, they go through a lot when they go through treatment. It has a significant impact on their quality of life. And then, they have feeding tubes placed. They can sometimes have trachs placed. They can't move their necks. And it causes, severe depression. And so, that can unfortunately lead to suicide in many of these patients. So how did I get interested in this? Well, I did a study when I was a fellow where we were looking at our patients who got chemotherapy and radiation and just sort of looked at their feeding tube outcomes. And in the oropharynx, it was amazing that if you had pre-treatment swallowing exercises given and you were not, and you compare that to patients who didn't get those swallowing exercises, you're 24 times less likely to have a feeding tube. So that means that if you actually did some exercises prior to treatment and during treatment, you were significantly less likely to have a feeding tube placed. So that's huge. So that means that if we do some sort of proactive treatment, we can reduce side effects. Okay. And that doesn't just apply to the swallowing function. Okay. There's a lot more that goes into it. So, and that transitions into lymphedema. So let's talk about lymphedema first, and let's define it. So, as we know, a third of the body's lymph nodes are in the head and neck. I actually sometimes will quote that more than 60% of our lymph nodes are in the head and neck. And as the cancer is treated, whether it be through surgery, radiation, there's going to be damage through the lymphatic system. And what that does is it creates an issue with sort of swelling that happens with accumulation of fluid within the interstitium, which is the areas between the cells in our bodies. And that fluid can become secondarily inflamed, and then that leads to scarring, which can occur both internally and externally. And this is the definition of lymphedema. How often do we see it? Well, lymphedema is actually present in about 90% of our patients. 75% of patients actually have moderate to severe lymphedema, and about half end up getting moderate to severe fibrosis. So these patients present with dysphagia, pain, discomfort, tightness in their neck, reduced range of motion in their neck, difficulty breathing sometimes, and sometimes they have changes in their voice and swelling, which can be seen internally and externally. What we can see again are like external swelling in the around the periorbital area, like in this patient. You see swelling along the neck. And what's critical to remember here, and I'm going to continue to focus on this, is that it can occur internally and externally as well. Okay. And this was some data that was presented actually at the DRS, which is the Dysphagia Research Society meeting. This is a poster out of Australia, and they looked at that internal lymphedema was still present long term. And so this is a patient that has, that there's no lymphedema. This is a normal endoscopic view of the glottis. And then you see what lymphedema looks like, this huge epiglottic thickening. You see the bulging postpharyngeal wall, and obviously you see the enlarged or the edematous sort of arytenoids. You see this sort of like fluidy look along the glossoglottic fold, and you really can't see the glottis. These patients, they have sort of noisy breathing. They have limited laryngeal mobility, and that's critical. That's important to recognize. And so what you see is that in these patients, almost all of them have some sort of internal lymphedema, and it persists in 2/3 of patients at about a year. So why is that important? Well, if you look at the external lymphedema numbers, again, 70% had external lymphedema. And that sort of went down to almost 10%. And so what that's telling me is that externally the sort of interstitium is finding ways to drain that fluid. However, internally they're not. Okay. And so what's important is that there's actually two sort of divergent patterns going on, is that the external lymphedema seems to be improving, but yet the internal lymphedema is not. So we need to address it. Okay. And so we need to figure out ways to treat it. So I wanted to just sort of quickly do a poll. And so just kind of saying, what percentage of cancer survivors in your programs are getting some type of lymphedema treatment? All right. So this is slightly concerning because what I'm seeing here is that really only 1/3 of people are saying greater than half of their patients are getting some type of lymphedema therapy. We'll get into it in the end, but hopefully you have an capability to sort of provide some comments to our moderator, who's Brittany, but just sort of, through the rest of this talk, if you have a moment, just sort of say like, hey, what are what do you think that the reason is that if it's so prevalent in the community, what are the barriers for you guys in terms of having these patients getting treated? So, all right, cool. So there's different ways to sort of diagnose some of the lymphedema. Some of it's imaging based. This was great data from Vanderbilt, where they looked at sort of predictors for lymphedema using CT scans. They looked at 3 different places: the submental fat pad, the epiglottis, and the prevertebral thickness. And in the bottom slide, you can kind of see that there's some fat stranding in this patient. You see this epiglottic thickening, and then you see the prevertebral layer is significantly thicker. And that's sort of indicative of someone who has lymphedema. And again, sort of they have various measurements of epiglottic thickening. You can kind of see sort of this is the normal, sort of mild to moderate, and then again, the moderate to severe. You see the prevertebral fascia. Again, you can measure that off of the spine. And then this is the prevertebral layer. And you can clearly see in this gentleman that, like, how much thicker it is than this. And then the submental fat pad. This is very clear submental fat stranding, which we see. It's not really applicable in sort of real life settings, but I mean, it's really nice that you can actually diagnose this, because if you see it, and again, we'll focus on this as well, or the theme of this talk is you see it on the outside, you actually end up seeing it on the inside too. So again, another poll question: are you currently aware of internal lymphedema in your head and neck survivors? Cool. That's good. That's excellent. So, I mean, 2/3 of people, responders are looking for it. I mean, that's a critical thing, because that means we're aware that it actually does have impact. Whoops. So, how do we treat head and neck lymphedema? Well, patients really do respond well when there's multiple layers involved with the treatment. One is through sort of a professional referral. So through Rush, like we have, it's actually an oncologic rehabilitation program called Revital that we refer through, and they have combination lymphedema therapy. They provide physical therapy as well. But speech language pathologists do a great job. Brad Smith, he was at MD Anderson. He's now, I think he's in Dallas now. He provides, he's a speech pathologist, does great lymphedema treatment for patients. And naturally just educating the patients. Home management is important as well. There's exercise programs, there's manual lymphatic drainage, just sort of elevating yourself, and then those funky compression garments that people can wear. They're sort of like the wraps that you see. They're the patients that you might know who have breast cancer who wear the compression dressings. You can also wear it around your neck and your face. And then what we want to talk about really is this Flexitouch, which has sort of really changed how I approach patients with lymphedema. So Flexitouch, it's made by Tactile. It's a pneumatic compression. It's sort of like wearing an SCD on your chest and your face, but it's a nice massage. It's it stimulates sort of lymphatic drainage. It provides something that patients can wear at home and gives excellent symptom relief. And you do it really in 30 minutes. So, what I tell patients is that, put on a show, By the time the show's over, you'll have done you've completed your treatment. The great thing is that Tactile sends a representative to your home. They do a fitting. They do all the service for it, and make sure that you're satisfied with the product. So, does it work? Well, this is sort of infrared fluorescent imaging that was used to sort of show the flow of lymphatics within the body. So, this is a patient who has dysfunctional lymphatic systems. You can kind of see the pooled, I guess, you would just call this is lymph, sort of pooled in areas in the interstitium. And if you have sort of functional lymphatics, you can kind of see what normal flow is like, where it's nicely defined, flowing down in. If this, you would actually, if this were a dynamic video, you would actually see it heading in that direction towards the bottom. So, do patients respond to the treatment? Well, this was a study that was a pilot evaluation of using this near-infrared fluorescent imaging to sort of show that it actually works. And so, this is a patient who is sort of dysfunctional, sort of lymphatic flow. You kind of see it sort of cluttered everywhere. And then after about 2 weeks of using the Flexitouch, you see sort of more defined gravitational flow of the lymphatics, and you kind of see it like traveling down. And then, symptomatically, these patients were feeling much better in terms of their neck swelling. And then half of the patients reported some improvement in their swallow function. So, more importantly, is it easy to use? Yeah. It is. And this was survey data obtained through Tactile, where the patients really didn't need any help to put it on. And they were able to put it on and take it off without any help. So it's very easy to put on, take off. You do have to get a little practice at first, but once you get it going, it's not a big deal. So the follow-up, though, is that once you wear it, is it comfortable? Yeah. 80% of patients found it very comfortable. And, once they went through a trial period, most of the patients said, if not all of them, said that they'd be willing to use this therapy at home. And after sort of single use, they felt better, and they found the device to be comfortable. Okay. So, how does this compare to sort of standard manual lymphatic drainage and self-home programs? Out of Vanderbilt, they did a really nice randomized study, and it's amazing the amount of significance that they found, because it was such a small number. It's only 40 patients total. And so patients were either randomized to getting Flexitouch plus sort of a self-management program versus self-management alone. And they used this daily for 8 weeks. And what they found is that, patients were having 4 times greater improvement in swallowing solids. They had stable pain levels, whereas the self-management folks, after 8 weeks of trying to do their own manual lymphatic drainage and exercise programs, their pain went up. And what's important is that their swelling went down. A quarter of patients saw a decrease in, there was a 25% reduction in swelling for the patients. The self-management group, their actually swelling went up. So really important to recognize that that Flexitouch helps. Okay, I think it overcomes the limitations that we see when we sort of have the patients do their sort of own home management. And can we generalize this? Well, if you look at 200 patients who received the Flexitouch, they noticed that they had much greater ability to control their lymphedema at home. They had increased or decreased level of difficulty breathing. They noted that their pain was improved, their swallowing was improved, and lymphedema did not impact their daily living. So just using this device has improved these patients' quality of life, and it's only 30 minutes a day. So do we have any real life examples? Absolutely. Okay. This is just a single treatment effect. And so this is a patient of mine who had an oropharynx cancer. Now, he was treated in 2011. And, I just saw him in 2019. And this is 8 years down the road. And I sort of noticed, a lot of like bulbous sort of the bullfrogging. Okay. And I said to him, I was like, why don't you try this device out? See how you feel. And this was just a single treatment, just amazing. Like, you see his jawline again. You see sort of his neck crease again. It's amazing, like what that did for him. And you kind of sort of see how like there's better contour to his face. Okay. So you imagine if this was on the outside, what's it like on the inside? Okay. There's another patient of mine that had a base of tongue cancer, and, he's a person that I wish I got him involved a little sooner, because, he had, he could feel his neck getting tight. And he did sort of lymphedema program through his occupational therapist, and really wasn't seeing any benefit. And so then I referred him on to for Flexitouch, and this is just one treatment. Okay, and you can kind of see that this was his before, and you can kind of see his after, like just after one treatment. Again, you see the wrinkling in his neck again. You see sort of like, you don't see that bulbous look. Not a dramatic thing, but this is just one treatment. Okay, so, and then if you continue to use it, what happens? Okay, you see, just after a few months, you see reduction in sort of the swelling. You see this gentleman is now capped, which is amazing. And then, continued use, and, he is decannulated. You can kind of see like a month later, he didn't really use it that much, and you can kind of see the little recurrence in the swelling, but just amazing effect of just using this one device. Okay. So what happens if you don't use it, right? And so there's a patient that continued to use the Flexitouch, for 2 months, and you'd see significant reduction, or there's not really, you have a nice epiglottis. You don't have a baseline to compare to, but you have sort of a nice thin epiglottis. And then he took 2 weeks off. And then look, you start to see a little bit of thickening in the epiglottis. And then you see sort of a little more swelling along the postcricoid area. So just sort of shows that in just a few weeks after not, using treatment for your lymphedema, you get, you can get a recurrence in your swelling. So these are sort of my future directions is that, can external lymphedema truly correlate with the internal lymphedema? And does treatment of the internal lymphedema result in improved function? Well, yes, it does. So this does not relate to Flexitouch, but this is data out of Barb Murphy's group in Tennessee. And they looked at 80 patients who were treated for head and neck cancers, and half of them were oropharynx. They used sort of an objective scoring pattern, subjective scoring pattern to look at internal lymphedema, and they correlated to some external scores as well. And they assessed it at time points during therapy. And patients also filled out a dysphagia outcome severity scale and then also a national outcomes measurement system. And they found that there was significant correlations between the severity of internal swelling at specific sites on the Patterson scale. This tended to be stronger in the dysphagia quality of life scales as well. So there was also correlates of that the external swelling as measured by the Foldy were also statistically significant. So that means that these patients were clearly having an impact on their swallowing function, and it correlated to their external swelling as well. So external lymphedema does correlate with the internal lymphedema. And if you actually see the external swelling, it may correlate with functional outcomes. We really need to work on some quantitative measurements. So what's the future here? Well, there's a clear benefit of single-use pneumatic compression that can be used to study the effect of internal lymphedema. So we need to have some correlates of pharyngeal function that we can use to study, and that's something that our group is currently working on. So in summary, surviving head and neck cancer is the primary objective of any treatment. So you can't really study quality of life after treatment if you're dying of your cancer. So, that absolutely has to be our primary objective. And we're doing a pretty good job of it. And so, but each treatment does come with its own set of side effects. And we really need to focus on having these survivorship plans with proactive treatments, be present as part of our multidisciplinary program to really reduce the treatment-related morbidity and mortality. Oops. I will say the NCCN actually does recommend lymphedema therapy, swallowing therapy, and it's part of the guidelines. And so, we can see this physical medicine rehabilitation that includes therapy for lymphedema and speech and swallowing therapy. Really critical, okay, that even our guidelines say this, okay. So what are our barriers? And hopefully a few of you have been able to sort of provide your own barriers, but really, it's awareness, right? How aware are we of the impact of lymphedema? And how aware are we of treatments and how to provide treatment? So, I'll say this, I knew about lymphedema, but I wasn't really keyed into it. So I had one of our physical therapists actually reached out to me and talked to me about lymphedema. And so, that sort of started the workflow for me to say oh, wait, there's something to it. I attended attended an education program, and I saw an oral surgeon talk about proactive trismus therapy. And so then I was like, oh, wait, so there's, if you're proactive in a lot of things, we could potentially reduce the side effects of this, and going to webinars, kind of like this one, right? And so, but in practice, what are some of the other barriers? So once you actually sort of are aware of, lymphedema and its impact and potential treatment options, what else is there? Well, with Flexitouch, it's cost, right? There's high deductible plans, obviously. So patients are faced with higher deductibles, and so they have to pay a lot of out of pocket for the device. And then, Medicare and Medicaid, they don't cover it. And Tactile's working really hard with the NGS in terms of trying to get coverage exception for head and neck lymphedema. But, they do have programs in place that can sort of help the patients get the device. So even if you have a patient that has a Medicare or Medicaid, there are programs in place, whether it be donation, whether it be ways to sort of refer through their supplemental insurance that is attached to their Medicare, their secondary insurance. And so there are ways. So what's important is that you put the referral in And they have a great group of people who are in place that are there to help take care of the patient. So, and what's most important is that, if we have our team, right, that is involved in, the cancer care, and, every component of this group, is involved. And, as part of our rush team, all of these groups, except the primary care physician, is engaged in the multidisciplinary care. And I think that that's important. So, and that's sort of where we sort of end off here is that just sort of like acknowledging sort of our team, at least my part, is that, our head and neck team is amazing. Kirsten, Samer, Ashley, Nikhil Joshi's a fantastic radiation oncologist, and Mike Jelinek and Mary Jo Fiddler are medical oncologists. Josh Teicher is our speech pathologist, but we have multiple speech pathologists at Rush. However, Josh is only focused on taking care of our head and neck patients, and he's done an amazing job. And then our nurses, our nurse navigators, Holly Sheltons, and then Elise and Pauline are our clinic nurses. I special shout out to Kate Hutchison at MD Anderson. If any of you know Kate, she's just a fantastic person. She was getting her PhD when I was a fellow there, and we've stayed close friends since then. And but her focus on sort of quality of life improvement really jibes with me, and I have a lot to thank to her. So, and then obviously our group at Tactile, Tracy, Sarah, Megan, Brittany, thanks for putting on a great program. I wanted to introduce Gail, our patient, and because it's important, that you guys as a group sort of hear it from me. You can hear some fun data and, cool slides and show some pictures, but it doesn't really have impact until you hear it from the patient. And one of the, quickly just on Gail had a tonsil cancer that we were able to treat robotically. And she had adjuvant radiation therapy after that. But, Gail sort of really exemplifies what our patients deal with and how they sort of acclimate. I still remember, this has had, I don't know if Gail remembers this moment, but I think it was about 4 years after treatment. I was just seeing her for a follow-up, and I walk in and I just said, "How's it going?" And I said, "I'm fine." And then I said, "You're fine?" And she goes, "No, I'm not fine." And then she went through this laundry list of side effects she's had from treatment. And it just sort of shows these patients are living, but they're living a new normal. And what Flexitouch is, what swallowing therapy is, what fluoride trays are, they're ways to sort of make that new normal a little bit better. And so, and Gail's great. And I wanted to give her sort of an opportunity to kind of talk about her journey, and in terms of how she came about using Tactile and the Flexitouch device. For me, what, Tracy is our local rep for Tactile, but, she does a great job, but really Gail keyed me in on the Flexitouch because I saw her in clinic that one time, and I said, "Your neck looks really nice. What have you been doing, wearing that wrap?" And she said, "No, I've been using that device you told me to get." And so anyway, so I want to turn it over to Gail.
Thanks, Dr. Bhayani. I think that you hit on so many points. And one of the things, I'm very grateful for my entire medical care team, because it was really important for me to be very proactive in seeing all the different disciplines, everybody from the OT, especially who I first started doing my lymphedema therapy. And I have to explain that my initial introduction, because I was given the opportunity to see a lymphedema specialist through this occupational therapist over a period of 8 weeks from pre-surgery, in anticipation, and in between surgery and radiation, I saw a physical therapist, and then after radiation was concluded, so for an 8-month period, I saw an occupational therapist who performed lymphatic drainage on me. And that was pretty much the start of all this. Since that time, I think that as much as compliant as I am, as you know, I think that when you are home and you are doing all your speech exercises and your lymphatic drainage, and you are trying to find ways that you can actually swallow and deal with your dry mouth and all the other side effects, that things just sort of fall to the wayside. And so it was really important that to explain how important pre-treatment is, and I'm just repeating what you said about the profound impact that it has on your quality of life and outcome of your treatment side effects. And so when I tried to do lymphatic drainage, and then when I went to go see a physical therapist, and I also saw Brad from MD Anderson at the time. I was very lucky he came to visit at a hospital, and I was used as a model of a patient, and I was fitted with all these different compression devices with little sponges and things that surrounded my head, and they were all a fail. I don't know how else to put it. Just I was supposed to wear these compression devices at night, and I felt like I couldn't breathe. And so I kind of floundered. I did my lymphatic self massages, but I floundered for quite some time until you told me about the Flexitouch. And so I purchased one and have been using it diligently every single night. And so I have to believe that it is really helping me in that it's a no-brainer. It makes it easy to do, because it was very cumbersome to try to use anything else, to do anything else as far as trying to get to get rid of this bulldog look, I'll call it. So, and combined with sinus problems, I really felt like I was always puffy. So that has had quite an impact on my life. I think that if I had a choice, if insurance wasn't an issue, I think I would go see an occupational therapist and a physical therapist and a speech therapist every day of every week of my life, because I believe in the whole idea of constant reminders and constant diligence with regard to having to do these strengthening exercises. You have to keep up with it, because as you said in the one slide, you take a break and you can start to fall back. And this is a lifelong process. So for me, it has been quite helpful in having something that is very easy to use. I sit in a recliner and I watch television. So that's my experience with the Flexitouch in particular. But I could also talk about many other aspects with regard to speech and physical therapy that have also helped in the grand scheme of things with regard to my therapy. Thanks. And of course, if anybody has any questions, I'm more than happy to answer them.
Cool.
Okay, well, I'll jump in here. Thank you, Gail. Thank you, Dr. Bhayani. We do have some questions coming in, and I'm going to try to group them together. Great engagement with the audience. And First, I will say, just to clarify, something about Medicaid. So Medicaid does cover, Medicare does not cover Flexitouch. Medicaid does, depending on the state. So some don't, but some do. And many commercial payers do cover it. But as I was having a conversation with a couple speech language pathologists, they were saying that it's their duty to make sure that the patients are able to get the best possible quality care. And so they refer everyone because it's up to the patient ultimately on if they want to accept and pay for the device. So I thought that was an interesting way to look at it as well. So Dr. Bhayani, we have a few that are talking about when can you treat head and neck lymphedema? Like how early can you start treating it? And then when do you refer to speech in these patients? And so it's kind of lymphedema in general. And then also building upon that, how early and when do you refer Flexitouch?
So it's been variable. So and this is a process, this is an evolution, but I refer, like now I refer much earlier than I used to. So, at the first sign of sort of seeing, sort of lymphedema, I make a referral. I actually put a referral in for occupational therapy, and I put a referral in for the Flexitouch. So patients are doing both concurrently. Before I used to wait until after someone tried, Flexitouch, but now I've sort of transitioned away where instead of waiting, because sometimes what happens is that and this is not a negative against the person providing the therapy, but it's just, we've seen sort of like the patients just struggle with, like doing the therapy themselves. And also, they can't go every day to the occupational therapist. They really can only maybe go once a week, if that. And so, so trying to get patients in sooner, into Flexitouch is what I've sort of changed or adapted my practice into, which is, so like if I've done, I've done bilateral necks on someone, at their 2-week post-op, I'll get them into, I'll get them a referral.
Okay. And then here is a question. Do you refer to therapy, CLT, OT, PT after completion of cancer treatment or during cancer treatment?
So we tend to do it sort of right at the end.
Mm-hmm.
And so, like right at the end of like the radiation therapy, we'll see, we do a 2-week toxicity check, and at that point, we'll sort of make that first call to sort of say, hey, how's your pain? Like if they don't have like any burns on their skin or anything like that, we'll make the referral then. However, there are folks, they will refer, even with the burns, because it's the garment itself isn't too painful. It doesn't have that much of an impact on like if the skin is really denuded.
Right. Okay. And here is one. Sounds like this would be something that would be beneficial to start in a prehab program and continue use through their radiation treatment. One thing I will note is that most health plans require the use of conservative therapy, like compression, elevation, and exercises, and then significant remaining symptoms of lymphedema for coverage consideration of pneumatic compression. Would you consider that as something in a prehab program, Dr. Bhayani?
I think it would be very challenging. It's a great question, though. It would be great to sort of jumpstart things a little sooner. But The challenge would be, again, like you mentioned, Brittany, is insurance. They're going to want to see some sort of therapy being put in place before allowing the garment to be put on or get covered.
Yeah. Here, I'm a CLT and treat patients during their radiation treatment. Would you recommend Flexitouch as an adjunct tool for them to decrease risk of post-radiation treatment effects?
Oh, absolutely. Absolutely. Yeah.
Here's one. What are your thoughts? We don't hear about this much, but what are your thoughts about some doctors saying that early lymphedema treatment can cause spread of cancer throughout the lymphatic system?
I've actually never heard that.
Really? Okay. I heard a couple, like very rarely, but obviously this person has heard about it. So
I don't.
Right. Manual lymph drainage is.
I mean, I think that one of the critical things is that ensuring that that patients have had a complete response to treatment, but I don't think so.
Have you seen Flexitouch help with patients with fibrosis?
Excellent point. Excellent question. Whoever asked that, because I wasn't sure about it either, because one of my thoughts was, it's too late. The lymphedema, Flexitouch is more a fluid-based issue, but I've now had, I think, 3, maybe 4 patients where I've started to say, why don't you try it out? I have a patient who has this brachial plexopathy after chemoradiation for a tonsil cancer, and she's only been using it for probably, I think, 2 to 3 weeks now, and she says that it's really helped loosen sort of her neck, like on a daily basis. And she said, that she's one of the most compliant patients you'll meet. And she's like, I'm digging in there all the time, trying to get out all these little knots and things that are sort of compressing on her sort of, brachial plexus area. And she said, it's too hard to do all the time. And she says, with the Flexitouch, it's really changed how things have changed for her. So it's another component where I need to sort of investigate a little bit more, but I'm seeing benefit for patients.
Okay, great. There was one that says, what is your theory about why Flexitouch seems to be more effective at managing internal lymphedema than manual lymph drainage? And that seems like maybe it's a compliance thing, right? Those exercises are hard to do, like you just said, on your own.
Yeah, no, I think so. And then, as Gail sort of alluded to, is that it's hard to do that every day for yourself, right? Mm-hmm.
And there are actually a couple of questions for Gail. Gail, are you able to come back on for a second? I'll give you some of these questions. Great. Okay, let me find them. So question for Gail. Curious to know how much her speech was affected from treatments. I'm asking because I'm a patient 3 months out of chemo radiation and concerned about my speech not progressing. Gail's speech sounds great.
Actually, again, another thing that I was very proactive about, I did see speech on several occasions, but it wasn't so much for the actual speech as much as it was for swallowing, because I couldn't swallow. And so I actually had to do had a lot of swallow tests in order to be able to start swallowing again and starting to eat again. Speech, it was just a lot of E and O and a lot of different exercises, and I never was a singer before, and so it was just a lot of exercises working with speech. That's the best that I can say, and a lot of the problems also is combined with the swallowing and the dryness, and that makes a huge difference. And so the only thing I can really say is the speech therapist was very instrumental in helping me make my voice stronger. That's I guess that's the best way to put it.
Right. And there's another question for you. Gail, did you stop using the wraps and compression garments after you started using Flexitouch? And how often do you use the Flexitouch now?
I use the Flexitouch just about daily, every evening. And the compression devices, they just were not comfortable. They just don't fit right. And I've had many different types custom made for me. I actually purchased some prefabricated materials that you actually put over your head like a mask. But they just didn't work for me. So I do not use any of those anymore. I just use the Flexitouch. And of course, I still will accompany it with manual lymphatic drainage when I can. So that I just want to, can I just go back to the speech person for just a minute? I just want to say that those exercises, I mean, they were vigorous exercises. They were laryngeal, tongue exercises. They were not oral motor swallowing. It was a whole slew. So I don't want to downplay that they were just voice exercises. There were significant oral exercises. Sorry. Thanks.
Thank you. That was great. And let's see. Here, Dr. Bhayani is a therapist, I believe, and I see that during radiation, she sees the first, or this person sees the first sign of lymphedema during radiation. And this person wants to start doing MLD and use a pump, but my docs are concerned about METs. But then I see their quality of life diminish. Any suggestions on how I get my docs on board of earlier intervention?
Send them to me. Give them my email address. No, I mean, I think it's a challenge because, a lot of folks, they're, I don't know if they're, I don't think that the metastasis component is, I just don't find it to be valid. I guess I'd have to look through the literature a little bit more, but I've never really, never heard that before. And so, but as far as getting your physicians engaged, just keep plugging away with them, go to tumor conference, and talk about, what's going on with these patients, make it known, because if you, like our Josh, who's our speech pathologist, he comes to every tumor conference weekly. When I was at my previous institution, speech pathologists came to every head and neck conference. And it's open to everyone to come and attend, because, if you show that you're engaged in taking care of these patients, parallel to the actual cancer treatment, these patients, I think the providers will actually see, like, hey, we've got to focus on this and we've got to make this happen. If you have a nurse navigator, talk to the nurse navigator about making sure that they get engaged into these programs. And so the patients get engaged. And so there are ways to get through it. And I think that, I'm more than happy to talk to anyone at the end. So I don't know. Do you guys give them my email address? Do I have my email address?
We can figure out a way to do that. And this presentation will also be on our website in the next day or two. So you can click back if you want to hear anything again. One question is the Flexitouch indicated as a lifelong treatment, or do patients eventually get rid of the fluid?
So that's another fantastic question. So it's usually unlikely that they're gonna create new lymphatic flow, because the radiation is, either the radiation or the, surgery, not so much, but with radiation therapy, it sort of, it spans the entire head neck. And so the lymphatic flow is significantly damaged. Now, obviously with, better treatment design and less dosing to sort of the unaffected areas, we may see some improvement in that. But it's not likely, and patients wear it are more than likely going to have to wear it for a while. I've seen patients who wear it for like 3-4 years, and then they notice significant improvement. They stop wearing it every day. They might go to it every other day or every few days. But when they do notice a little bit increased swelling, they put it on and they wear it for a few period longer.
Okay, here's a couple kind of more technical questions. With metastatic cancer, can we perform MLD and compression locally, or is it contraindicated? MLD.
I guess it depends on where if they're dermal metastases, probably not. But if it's, if we're talking like someone who has longer liver mets or that are outside of the head and neck, it shouldn't be an issue.
One more question. I'd like to talk about your program briefly. You listed a lot of people that were on your team on one of the last slides. And do you have this question is, do you think you would see benefit from therapy, OT, speech during treatment? Do you have a prehabilitation program? So how do you go about treating these patients pre and post in your clinic?
So with the pre, I mean, so in terms of like physical therapy and occupational therapy, like in the pre-treatment setting, it's more of an awareness and not necessarily that they're getting treatment. As far as for speech pathology and the dietitian, the reason you want to sort of get them engaged in sort of like an aggressive sort of prehabilitation program is that, if you get the patient's mindset thinking about some of the swallowing dysfunction that might occur, you can sort of make changes. And then also with the dietitian, the patients can get prepared and like go purchase what they need to purchase and be ready for that when the time comes. As far as like the sort of external sort of lymphatic or treatments, it's really hard to sort of get patients into it and also get them engaged because sort of the skin changes that occur during treatment, no one's going to want to let anyone touch their neck. And so we tend to avoid it. But I know that there's groups actually in Colorado. I met a physical therapist, and she's providing at least a little bit of light treatment on the neck in those settings. But really, it's just really hard,
I think we have time for just one more question. So here, I'll finish with this one. Based on what you said about radiation treatment damaging lymph flow, why not recommend Flexitouch to everyone after radiation?
I do.
I thought that was a nice one to end on.
Yeah, I do actually. I mean, I let them know about it.
Okay. Well, great questions, everyone. Thank you all for the great engagement. And I will close by just showing this slide. We do have more webinars that you can log into and view in the near future here. Go to tactilemedical.com/education to do so. And Dr. Bhayani, thank you so much for your talk. It was very educational and engaging, and I hope everyone on the line enjoyed it.
Great. Thank you guys for attending.